Thank you so much, Sharon, and thank you to you and to AFTD for the invitation. It's been a, I think, great conference so far, and thank you so much for organizing and inviting me to speak. I'm very honored to speak here. And AFTD, you know, as all of you know, is such a wonderful patient organization. It does so much for these patients. So thanks for all of that as well. So I'm going to speak on a topic I feel strongly about, which is distinguishing behavioral variant FTD from psychiatric disorders. We'll talk about distinguishing from other disorders as well too, but this is something that happens, comes up frequently, and I think even in the chat we've been seeing this. I don't have any anything to disclose. I'm going to try to go through the slides pretty quickly so we have some time to get to some of the questions that we've been seeing so far and are coming in. So talk a little bit of, give a case, just singular. A little bit of background on FTD. Again, I know a lot of people, you know it and won't spend too much time on it. Spending a little more time on what are the symptoms of FTD, and then kind of getting into how they differ from symptoms of psychiatric disorders and Alzheimer's disease, and then the workup and the examination as well, and how that can help us distinguish these, make a good diagnosis, which, as you guys know, is a big problem in FTD. This is someone I saw when I was a fellow, so many years ago now, one of the first FTD cases I worked with, 56-year-old woman. And about 3 years before I started seeing her, she started acting out of character. She was doing some inappropriate behaviors, flirting with people, giggling, calling old boyfriends. She was a teacher, and at one point got annoyed with her students and cursed at them and walked out of the classroom and just got in her car and drove away without providing for any supervision for them. An action among other actions which got her fired from her job. She was apathetic, not as interested in doing things. The husband had noted that she was having trouble working her email, using her phone, kind of performing complex tasks. She was eating more sweets and drinking more alcohol. She had also, she had been initially diagnosed with depression, but then was, the husband went back to so was seen by primary care doctor and then by psychiatry. The husband went back to the psychiatrist and said, oh, you know, I think this isn't depression, and then got an evaluation, and then was diagnosed with FTD, and then saw us. But it was about 2 to 3 years into the disorder that this happened, and that's pretty typical. Many people, the majority of patients with FTD are misdiagnosed either as a psychiatric disorder or another neurodegenerative disorder, and spend an average of several years before the correct diagnosis. This is her scan. And as you can see, she's having, she has, you know, there's a lot more space here, which is the black part here. In the frontal lobes, the back of the brain, it looks fuller and richer, as opposed to with the white and the gray being brain and the black parts being space. You can also see here, this is what we call a sagittal view or side view. And there's let me turn on my pointer here. There is the front of the brain has this you know, what they call sometimes a moth-eaten appearance, and then the back of the brain looks quite good. And this is quite characteristic of frontotemporal dementia, which has a very strong tropism, we call it, meaning it really kind of tends to focus on the front of the brain, and the back is much more preserved. This is her PET scan, which can offer an FDG PET scan, which can be useful in diagnosing this disorder, and it showing, and you can see that the cool colors are there more cool colors in the frontal lobes, especially on the left compared to the back. A little bit of background. Again, I won't spend much time on this. I know you people all know this, but the peak of onset is different from other neurodegenerative disorders. It's midlife as opposed to late in life. It's about equal in prevalence to Alzheimer's disease in patients who have dementia, early onset dementia, so less than 65, reflecting the relative early prevalence of it. Obviously, as people get older, the Alzheimer's disease is much more common. And if you push it even younger, it becomes the most common form of dementia in patients under 60 years old. And overall, it's about 5 to 10% of all dementias. This is just a reminder, and I know you had a talk on nomenclature. It's quite confusing that we use this term frontotemporal lobar degeneration, which is the pathologic diagnoses that are compatible with FTD, but that it has many different clinical associations with that. So behavioral variant FTD, the 3 primary progressive aphasias, which are largely language symptoms, including non-fluent, semantic variant, and logopenic, primary progressive aphasia, frontotemporal dementia with motor neuron disease, and then the 2 Parkinsonian variants, progressive supranuclear palsy and corticobasal syndrome. All of which either share symptoms with or share pathology with behavioral variant FTD, which is what we're going to focus on today. The pathology associated is similarly complex, and this is a kind of a summary slide where it has the different diagnoses that form the FTD spectrum disorders, and it has colors on what the pathology is, with red being tau pathology, blue is TDP-43 pathology, and orange is Alzheimer's pathology. And you can see behavioral variant FTD is about half tau, half TDP-43. Semantic variant is more TDP-43, and then they vary between primary tau pathology, TDP-43, and Alzheimer's pathology. And for some diagnoses like AFTD ALS and progressive supranuclear palsy, you pretty much know from the clinical presentation what the pathology is. For behavioral variant FTD, it's pretty evenly split between tau pathology and TDP-43, and most of the time you don't know which is going on when you see the person clinically. This is just showing gross pathology, and again, showing a lot of volume loss in the front of the brain with the back being relatively preserved. Now, there's been some really interesting work that's made things a little more complicated, but more interesting in some ways, which is we're learning that this TDP-43, which is a pathology associated with ALS and with FTD, actually appears to probably be associated with other changes as well. And those of us in the field have known that a lot of patients we've been diagnosing with Alzheimer's disease actually have a lot of TDP-43 deposition, especially in the limbic areas of the brain, which are areas associated with behavior and emotion, to the point where these researchers defined this disorder called late limbic predominant age-related TDP-43 encephalopathy to kind of describe it. And it's probably about 15%, 10-15% of what we're calling Alzheimer's disease may actually be associated with TDP-43 pathology. So FTD, looking like it not so rare as we had thought to be associated with things. Oh, I'm sorry. Actually, let me. Oh, this was an older version of the. Okay, well, I'll just skip that. So the question is, so a very important question is, what are the early versions? I mean, the early symptoms of bvFTD. Actually, I think I am going to quickly end and upload them. I think I opened a not as up to date. Yes, this is not. Let me do the most recent copy. Sorry, give me 1 second. I apologize. I had 2 versions of the talk, and I think I opened the wrong one. But this will just take 2 seconds. I just want to be sure we get the right one. And there we go. All right. We'll go forward. Okay, there we go. So these, what are the early symptoms of bvFTD? Very important for the question of how we distinguish from the psychiatric disorders, and also of great interest in itself. I'm going to spend a little bit of time on this for a couple reasons. One is it's important for the question we're answering, and the other is because we have a new study just hot off the press, just came out a couple days ago on early symptoms of bvFTD, which you can get. It's actually, we made it available to anyone with an internet connection, so I'll show you the reference for that. These were the previous criteria. So back in 1998, there was a set of criteria, which was, they framed the symptoms at that point sort of broadly. They had early decline in social interpersonal conduct, early impairment and regulation of personal conduct. So again, kind of a little bit broad, one could even say vague, early emotional blunting, early loss of insight. In 2011, Kaczorowski and Bruce Miller, among others, decided, wanted to make new criteria, thinking these were a little too vague and not associated with pathology. So they did a great paper where they basically, redefined the symptoms of behavior variant FTD: disinhibition, apathy, loss of empathy, sympathy, repetitive behaviors, hyperorality, and then a cognitive profile that was consistent with bvFTD, which they defined as executive deficits with sparing of memory and visual spatial ability. And so these are the criteria we've been using since then for the last 11 years. It's interesting if you look back. So this is from that paper from Ruskowski and Miller. The symptoms that Neary was showing, so including impairment in interpersonal conduct, emotional blunting, were actually reported pretty commonly, but they felt that it was a little vague. This is the new paper. So this just came out last week in Brain. And like I said, if you look it up, you can get a copy of it. Megan Barker was the first author. I was the last author. And then it was largely, the data was, a lot of it was from all FTD, the large national study on FTD. This is Megan. And what we did is we wanted to answer the question, when we compare very early cases to controls, what are the symptoms that are really the earliest and best defined behavioral variant FTD and best distinguish it from Alzheimer's disease and psychiatric illness? So if you're looking at early FTD, you have to go to genetic cases. And the reason for that is this diagnosis. So most patients with sporadic FTD, we don't see until pretty late in, or kind of moderate in the illness, because of this problem of misdiagnosis as Alzheimer's or psychiatric. So we went and found 72 patients where we had evaluated them in research at this very early prodromal stage where they didn't have dementia, but they had very, very early symptoms. And we compared them to their family members, so people who didn't have mutations as the controls. And we were really interested in saying what symptoms distinguish are the mutation carriers who are having early symptoms from their family members. And then we compared them to patients with very, very early Alzheimer's disease. We really we're doing a follow-up study specifically on psychiatric disorders, but we didn't have the data at that time. This is a busy slide. You don't need to really get too into it, but the reason I'm putting it up is that just to show you kind of to get these 72 people, mutation carriers, where we have well, actually 55 of them mutation carriers, 17 of them were sporadic cases. But where we get some early information, we have to evaluate a lot of people. So many of you, I probably have participated in all FTD and other studies similar to it. We've screened over 1,300 to kind of get those patients that we can look at for the study. So only 308 of those were mutation carriers. We had to exclude 240 of those, and you can kind of go down the algorithm. And it's part of the reason why this research is so important and why we have to enroll such large numbers of people to kind of look at the people that we're interested in answering the questions. And the clinical question, we and I were most interested in this is someone having very early symptoms coming from a family with genetic FTD, and someone else in the family saying, do these symptoms represent FTD, or are they psychiatric or other? And which is a question those of us who see these patients in these families get asked a lot. And that was the kind of driving question behind the research. I won't get too into the measures, but we used a large battery of neuropsychiatric and behavioral measures, including a review of all of the records. So we wanted to be open to say, well, maybe they're having symptoms that are not in our measurement scales, but that are important for FTD. So we looked at all of these other symptoms as well. The cognitive measures, so we did a very full battery of cognitive assessment in all different domains, including in social cognition. We used measures of social cognition. And for those of you who aren't familiar with that term, that means the cognitive processes that help us interact with other people normally. So things like knowing what social norms are, self-monitoring behavior, things like that. And what we did, we wanted to kind of get a group of patients who we were really, really sure represented kind of pure early FTD, and then as our development group to test what symptoms worked best to diagnose FTD, and then to bring that into a validation group to see how it worked. So our development group was only 22 people out of those thousands we screened. But these people were really kind of as clean as we could get in terms of developing FTD. So they were people where we saw them prodromally, usually even before they got sick. And then they went on to develop full-blown FTD as we followed them in research settings. So again, really kind of basically from a research point of view, as informative as it could be for what were the early symptoms were in FTD, our gold standard. And then our silver standard were people where we saw them prodromally in research, but either they didn't have a mutation, they were sporadic, or we weren't sure if they went on to develop bvFTD for various reasons. For each symptom of bvFTD, we calculated sensitivity and specificity. So specificity is very important for ruling a disease in. So if they have that symptom, it's very informative for this question of, is this a symptom that reflects FTD? And sensitivity basically says, how common is that symptom? And we did a calculation which was commonly used to assess how useful this symptom is. We don't need to get into it too much, but called receiver operating characteristic curves. And one thing we wanted to do in these criteria is make them very data-driven. So it's not a failing, but one characteristic of most previous criteria is that they hadn't really been based on data. And some of that was they didn't have the data. And in the last 10, 15 years, we've collected a lot of the data that allows us to do this. So we basically said, we're going to put all the cognitive, all the neuropsychiatric, and all the social cognitive measures together. And this is what a symptom has to have for us to consider it a valid symptom. It has to have this area under the curve of 0.7 or above, which is a kind of a generalized measure of how good a test is. And then it has to have high specificity. And the reason for that is we really didn't want to have false positives. We don't want to be telling people they have FTD when they actually don't have FTD. But we wanted the sensitivity to be at least 0.3 so that it's a symptom that's pretty common in FTD. These are the results. And on this slide, here you can see I split it up into cognitive symptoms, including non-social cognitive symptoms, social cognitive symptoms, and then neuropsychiatric behavioral, with symptoms that met the cutoff of an area under the curve of meaning a good test of 0.7 or above in red, ones that did not quite reach that, but met our other criteria for sensitivity and specificity and an acceptable area under the curve are in blue. So a couple kind of take homes here. One you can see is that really our best performing symptoms were behavioral and neuropsychiatric. So what that suggests to us is that really, if you want to identify early bvFTD, you really need to do careful assessment of behavior and comparing it to any kind of differential diagnosis you have. And I'll go through what the symptoms that we found that were good are in a minute. Cognition, both non-social and social, did not perform as well. And there were a couple reasons for that, which I don't think I go into this slide, but I can tell you a little bit. Executive function, which we often associate with FTD, actually we saw it in almost all of our very early bvFTD patients. The problem was we saw a fair amount of executive function in our controls. It was not so good at separating out from the controls. And the same thing actually with the naming. I don't think I talk about memory here, but one thing we found with memory that was quite interesting is that we found that, so in the old criteria, memory is supposed to be preserved in behavioral variant FTD. We found that our very early patients had relatively preserved orientation, but actually performed often quite poorly on list learning, which is a common memory task where we have people remember words. And there may be, we don't know, but there could be several reasons for that. One is that list learning could be harder. So that people, may be putting less effort in and take more effort as opposed to orientation, which is a little more of a passive task. But one practical implication of that is that memory shouldn't, when you're thinking about distinguishing FTD from either controls or psychiatric disorders or Alzheimer's disease, we can't think of it as a blanket. We have to get into a little bit of how exactly we're testing it. So on the basis of these data, we made these are the new criteria for very early FTD. And we called it MBCI. You've probably heard this term, mild cognitive impairment, that we use in Alzheimer's disease and other disorders. We tweaked that to make it, we put in the behavioral because we said, well, these behavioral symptoms are really kind of performing well. Here they are. So you have to have 3 of these symptoms. Apathy without dysphoria. So this is new, we added this in. So the idea being, and this is what we saw in the data, people with early FTD had apathy, so decreased motivation, but they weren't sad, they weren't dysphoric. Behavioral disinhibition performed well. Irritability or agitation, this is a new symptom that wasn't in the old one. Loss of empathy, sympathy was in the old one. Repetitive behaviors performed pretty well, and we specified a little more what they were. This symptom is a new one in the new criteria, which is joviality or excessive gregariousness. So people who were kind of too happy all the time or excessive gregariousness. And one thing I think of with this is kind of like the typical symptom we would see with this is people who would approach babies on the street and kind of get in there too much without being sensitive to the parents finding that threatening. And then eating too much, appetite changes, hyperorality, which was in the previous criteria as well. We bumped down, so these are supportive criteria, and we bumped cognitive down to these, which may seem a little strange, but it didn't perform as well as these other symptoms. And then for the cognitive, we had decline on executive dysfunction, and naming, which was one of the better performing cognitive tests. And insight, which also did not perform well enough to be in the core criteria, but could be supportive. And then social cognition as well, measures of social cognition got bumped down to supportive. So interesting, some changes from our previous conceptualizations of early FTD, one of them being, the weighting of behavioral symptoms, so that you can actually get, by these new criteria, a diagnosis of MBCI due to FTD without cognitive changes, but based on the behavioral changes. And then some tweaking of the symptoms to make them a little more data-driven, a little more sensitive and specific to detect early FTD. When we do these, they perform actually really quite well. They correctly identify 95% of the development group and 74% of the validation group. That's not actually bad for the validation group. That we're to remember were the people, mutation carriers in sporadic cases we saw early but didn't have follow-up information, because some of those will go on to develop PPA and other kind of non-behavioral variant FTD. So that's kind of what we would expect. Our false positive rate was also good. It was quite low. Really, we give a range because we didn't have all the measures on AD that we have in the FTD, but it's probably in the lower range of that, like 11, 12%, and 10% for healthy control. So what that means is people who meet the criteria, these criteria are rarely Alzheimer's disease or healthy controls. So hopefully this will be useful moving forward for this really crucial question of someone's having early symptoms. Is it FTD? Is it Alzheimer's disease or a psychiatric disorder? Then the one next step we want to do is directly compare this with different psychiatric disorders. We didn't have these data at the time, but that's kind of our next step. So let's talk about differential diagnosis. As we've talked about, most of patients, the majority of patients, FTD patients, will not receive the correct diagnosis, which is pretty shocking when you think about it. I can't really think of too many other disorders which really have such a poor diagnosis rate. And there's been work by Tiffany Chow and others to show this is very upsetting to families in terms of, so sometimes people say, well, but we don't have treatments for FTD. Well, we do have trials and we will have treatments at some point, and in which case this will be worse. But even without treatments, it's very upsetting for families to kind of have it be diagnosed as a non-neurodegenerative process, and then to find out later it is neurodegenerative, and often several years later. So we're going to talk about, even though this focuses on psychiatric, distinguishing from psychiatric symptoms in this presentation, I'm going to just talk a little bit about Alzheimer's disease. So bvFTD, often having much more early changes in personality behavior. I think I made that case to you with the new data we're showing, that it really kind of the behavioral symptoms are early and prominent in FTD as opposed to AD. Social cognition deficits in FTD and executive function, which they both actually, and with relatively intact memory and visual spatial ability. We're kind of fortunate in distinguishing AD from FTD, the fact that the memory is relatively intact, although again, we would argue orientation more than list learning if you're looking at memory, and visual spatial ability, because these are two areas that are actually quite targeted in Alzheimer's disease. Most patients with Alzheimer's disease will have impaired memory and visual spatial ability. The cognitive area they overlap on is executive dysfunction. Both Alzheimer's disease and FTD will have executive dysfunction. bvFTD, much more likely to have motor symptoms and a family history of genetic. It's much more commonly monogenetic than AD. But then to kind of what we were focusing on a little bit, which is distinguishing from psychiatric disorders. This is a paper I was kind of peripherally involved in, but it's a nice paper. And again, if you want to kind of focus in on this topic a little more, I recommend it and to take a look at it. That was in Brain a couple of years ago, 2 years ago. And a lot of the things I'm going to talk about are in that paper in more detail. So in terms of the symptoms, we'll get later into kind of tests and other things, but in terms of, and biomarkers and things, in terms of the symptoms, these are some things that can help you distinguish bvFTD from a psychiatric disorder. One is cognitive dysfunction. So patients with FTD will generally, especially as the disease progresses, develop more cognitive dysfunction. Now, Sometimes people say, well, but if you look at cognitive testing, psychiatric disorders will have some decline in cognitive performance. That's true, but it's usually much more prominent in a neurodegenerative disorder, whether that be FTD or Alzheimer's disease, than in a psychiatric disorder. Progressive course, and so you can see a progression, especially cognitively, much more in FTD than in psychiatric disorders. Motor symptoms we talked about, rare in very rare in psychiatric disorders. And there's some motor symptoms, for example, symptoms of ALS, fasciculations, which are can't be elicited voluntarily. You can't make your muscles fasciculate and things like that. And so in terms of functional neurologic disorders, those can be very characteristic of especially FTD ALS. This next one, new onset of psychiatric disorder, age of onset, is one that I think is very important, which is if you look at most psychiatric disorders that are in DSM, or what I might call primary psychiatric disorders, they really are disorders of early onset. They're disorders of youth even to early adulthood. If you make it into middle age without them, they're relatively unlikely to appear later in life. And so when psychiatric symptoms appear late in life for the first time, it really should raise all of our suspicions of a neurodegenerative disorder or process happening. This next one of not fitting well into a psychiatric diagnosis is important. It's kind of looking at the other side of the equation, which is that if you're going to diagnose a psychiatric disorder, for reasons we don't fully understand, primary psychiatric disorders tend to kind of follow the same patterns over patients. And if they don't follow that pattern, that should, again, raise suspicion. So an example for that is I see a fair number of patients where the differential diagnosis is FTD versus a psychiatric disorder, and I'll read the history and they'll say something like, patient has bipolar disorder, diagnosed with bipolar disorder at the age of 55, which again is unusual to have bipolar disorder come about that late in life. Characterized by, patient has been manic for the last year and a half. Well, that also is very strange for bipolar disorder. Mania is really not a stable mood state, and people will usually cycle out of it. It's very, very uncommon for bipolar disorder for someone to be manic for that long. And so again, it makes you think this is probably not mania, actually. This is a symptom that I'm very interested in, and I think has not been given kind of enough thought or in terms of its clinical utility, is distress. So, in the criteria I went over with you for early bvFTD, it was apathy without dysphoria, without feeling sad. In general, patients with FTD will usually show bvFTD emotional blunting. So, and you saw that was for the NERI criteria, the older criteria. That was one of the criteria for FTD. It got dropped in the more recent ones. But patients with behavioral variant FTD will very frequently not show the distress that they really should be showing. So, when I'm seeing one of these patients or seeing them with one of my fellows, whether the differential diagnosis is between a psychiatric disorder and FTD or AD and FTD, one of the first questions I want to know is the person in distress? Are they upset? So almost all psychiatric disorders are characterized by distress, whereas FTD, they often are not as distressed as they should be. And how we see that clinically often is we'll be meeting with the patient and we'll be discussing, well, do you have a progressive neurodegenerative disorder? And the patient will not be upset as they should be. So, we'll say, well, we've reviewed everything, we think you have FTD, and the family will be upset, and the patient will say, well, okay, I'm bored, can we go? So I think that this kind of subjective being upset, being in distress is a very helpful tool when distinguishing either Alzheimer's or psychiatric disorders from FTD. It's a symptom that's pretty specific to FTD. And then deficits in social cognition. So bizarre behaviors that kind of would have been embarrassing before, again, much less common in psychiatric disorders. Oh, this is just speaking to that distress factor. This is a paper, we've published several papers showing both anxiety and depression, but that in patients with FTD, they show less anxiety and depression than we would expect. So in this study, we looked at the association between how depressed they were, how sad they were. And what we found was that it was strongly associated with the cortical thickness, so how thick their cortex was in the especially left ventromedial prefrontal cortex. But the thicker the cortex, in other words, the more preserved the brain, the more depressed they were. So really indicating that these patients with FTD were blunted, where they were not as dysphoric or depressed as they would have been with more preserved cortex. And this is another paper I did with Megan that just came out recently, where I think that this information, especially about the emotional blunting and lability and things like that, can be integrated into clinical pathways, where we really should be using this information clinically in conjunction with the cognitive and other data to help us diagnose appropriately. So the workup. So often more formal workup is very helpful. Besides, I was before talking about the symptoms we see, but more formal scales and other things like that can be helpful in distinguishing bvFTD from psychiatric disorders. So some things are scales, and I'll show you a couple scales. Another is neuropsychological testing, and even sequential neuropsychological testing, so that we can see, well, is it declining over time? Now, neuropsychological testing is very helpful, but it really needs a good neuropsychologist. As I've already said, the cognitive symptoms in FTD can be complicated and confusing, and it really needs someone who's very good at interpreting, for example, just divergent memory testing, as I showed you with the criteria. Imaging is obviously central. However, and we'll talk about it a little bit more, but qualifications in that patients can have early in the illness can have relatively preserved imaging, so there can be false negatives. Well, not false negatives, but preserved the brain looking pretty good on imaging, but a syndrome of FTD. You can sometimes see the converse, where people will not have symptoms of FTD, but will show abnormal imaging as well. So this again has to be examined carefully. Biomarkers, we'll talk about genetic testing and neurologic examination. I'll get to that in a little bit. This is, I was saying, the scales. This is a nice little paper by Simone Ducharme, who is doing some great, he actually authored that brain paper about distinguishing FTD from psychiatric disorders as well. And it's a checklist, basically. And I think for those of us who kind of do a lot of this, we don't need this. But for people who are new, don't have as much experience with FTD, it's nice to just know the symptoms and things you're asking about to help distinguish FTD from psychiatric and a lot of disorder. And a lot of these are symptoms you've been hearing me talk about. So emotional distress, are they aware of their problems, etc. But it's nice to put it in a kind of a little form there. Imaging biomarkers, we have mostly imaging. We have two types. One is structural, MRI or CT. The other is functional, FDG PET, or now we have Alzheimer, we have amyloid PET as well, and we'll have tau PET soon. And these obviously are really an essential part of the workup and can be helpful, but they can be overread and underread. Often the structural MRIs are underread, so that there have been studies on this where radiologists will often undercall FTD. So they'll say, oh, it looks okay, when really people who think when there really is significant atrophy. So again, these are supportive, but always should be evaluated in the context of the patient. Sometimes I think I run into a problem where the imaging is abnormal and people will prioritize it over the symptom presentation. So people will give a diagnosis of behavioral variant FTD with people who really aren't having symptoms or a course typical of bvFTD just because the imaging is abnormal, and I would argue against doing that. The neuropsychological testing, again, we've talked a fair amount about this. In theory, preserve visual, spatial, and memory abilities with impaired executive function, but with the caveat that memory tests are not all the same. Lumbar puncture, we have good CSF biomarkers for Alzheimer's disease. At the moment, this is most useful in that differential diagnosis with Alzheimer's disease. So that we often, if a patient we're thinking has FTD versus early Alzheimer's disease, a lumbar puncture can really help us with that. Not as helpful with psychiatric disorders, but there are, because we don't have CSF biomarkers for psychiatric disorders or FTD at the moment. But there are some interesting biomarkers coming down the pike, one of them being neurofilament chain light, which appears to be a biomarker that is associated with neurodegenerative disorders more generally, and that could end up being very useful in distinguishing FTD from psychiatric disorders, because if you have a patient where you're considering it, you could get it and it could give you a good biological indication of is there a neurodegenerative process going on or not, but has not yet ready for clinical use, but probably will be down the road. Obviously, the physical neurologic examination is very important to evaluate for motor aspects of FTD, especially Parkinson's and motor neuron disease, which are both very, very unusual in psychiatric disorders. Related illnesses, cortical basal syndrome, PSP, looking for kind of subtle neurologic signs, gait and eye movement abnormalities, especially apraxia. That case I showed you at the beginning had that. I think it's probably the most common physical neurological finding we see in frontotemporal dementia. Frontal release signs often don't emerge until later on in the illness, which those are primitive reflexes that can reemerge, may not be as useful early on. And I think the physical exam is a great kind of informal cognitive and social cognitive exam. So, as you're doing the exam, how is the patient interacting with you normally, or are they trying to touch your face or do things that show poor social cognition? And then the mental status examination, often patients with FTD may have blunted affect, narrow range, or bizarre behaviors. Usually, very, very rarely do they have depression. Usually they're not dysphoric. Repetitive behaviors, speech, often people, even with bvFTD, will have some aphasia. And then, as I've talked about, these social cognitive deficits. So I'll stop there about 10 minutes early, just so we have some time to discuss and answer questions. So let me get my pointer back and I will stop sharing.
Thanks very much, Dr. Huey. I really appreciate it. I'm
going
to ask people to put their questions into the chat box. I will try to pull them from there. And we will try to take advantage of the 10 minutes you've left us to get to as we can. I would like to ask you to talk a little bit more about the neuropsychological exam in the context of those emerging distinct behavior symptoms that you've identified, because I think that list that you provided and what the data is starting to support is those very early symptoms. That's certainly a list that resonates with people, certainly the folks that we talk with. Those are things that they would identify with kind of later on when the diagnosis becomes clear. But we also know the neuropsych exam is really important early on. Can you just speak a little bit to how that relates to these behavior symptoms? And
you're thinking the cognitive testing, those tests specifically, or So I'll give you and some of this gets into opinion more than data driven. I think when you're evaluating for Alzheimer's disease, the neuropsychological testing is more kind of consistent and reliable. So people, and that's often because of the symptoms of Alzheimer's disease, they're coming with primarily memory problems, visuospatial, they're putting good effort into the task. Those tests are kind of quite precise. We have a lot of data on it. When you contrast that with someone coming in with behavioral variant FTD, the testing gets more complicated and the interpretation gets more complicated, because these people, when you think about all of the assumptions that go into neuropsychological testing, for example, the person has to be motivated and put effort in. They have to want to please the examiner and kind of do what the examiner's telling them. Many bvFTD patients don't meet those assumptions. And so I personally think, and again, I don't have data for this is more my opinion, having seen a lot of these people, is that's why we're seeing this split between orientation and list learning. So that, if you ask a bvFTD patient the date, their memories or encoding is usually quite good. And so they'll just say, oh, it's whatever the date is. Whereas if you're asking them to do list learning, you say, okay, here's a list of words. I want you to memorize it and rehearse it. They just don't, they kind of will space out and they'll not, because they don't meet those other kind of criteria. So what you end up having though is that you can get test results which are not exactly characteristic of the patient. So you'll get, and you'll see this a lot clinically, early bvFTD patients who score terribly on the memory testing. Again, I think because they're not putting effort in, they're not, and motivation, and so apathy. So often patients, when you ask them to kind of, okay, what were those words I said? They'll say, oh, I don't know. And then, but if you give it to them in recognition, they can actually then get them. So the idea being, so it's neuropsychological testing can be very, very important in FTD, but in my experience, it's really important to have someone with experience, a neuropsychologist who worked with FTD patients before, and the testers too. So the testers I work with who actually do the testing are really, really good at staying true to the instrument, but getting the best performance, keeping people on task, keeping people motivated. Whereas people who are not used to working with these patient populations, may just, if the patient says, I don't know, they just move on without thinking, well, maybe the patient actually does know. So it's very important, but complex.
Well, and you provided us a long list of the different elements of a comprehensive evaluation. And I think part of what I'm hearing is that every part of that is still really important. There's no short for
to say
it
may not be as reliable, it doesn't mean it's not very, very important to cognitive evaluation. It just means, you got to kind of, you got to approach it as a little more complicated, I think, than what people are used to.
So I'd also like to ask, we have people interested in having you speak a little bit to differentiating depression and FTD. We know that's a critical issue.
So, you don't want to be glib about it, because I think they are really, if you make a Venn diagram, they kind of overlap on a couple symptoms. They overlap on withdrawal, they overlap on anhedonia, which means not taking as much pleasure in doing things. So often behavioral variant FTD patients will stop doing things they used to like. The thing where the Venn diagrams almost always differ on is this symptom we call dysphoria, which is a kind of a distinct symptom, which means feeling sad, feeling bad. And it has other things kind of associated with it. So like suicidality, poor self-esteem, those usually kind of cluster with dysphoria. And that's where they really almost all and this is what we found in our data and in the criteria, put it in the criteria, the FTD patients, so they'll have withdrawal, they'll have anhedonia, but they won't be dysphoric. And I think this holds up to my mind clinically. I mean, very often, most of the bvFTD patients you talk to, you'll say, how's your mood? And they go, oh, fine. I'm good, And I would argue, and I presented a couple slides on this, their mood is almost inappropriately good in some ways. Again, if you're talking, again, you put you or I in their shoes and are talking about having possibly a very serious and progressive illness, they're not as dysphoric as they probably should be, for that. So that's really the key symptom for distinguishing it. Now, I think depression is by far the most common misdiagnosis. And, you can see why it happens, because depression is really, really common, and FTD is quite rare, and people may not have experience with it. But when you look at these patients, one of the key things, and we had a patient recently diagnosed, well, I see this in the records, usually the people are pretty accurate at reporting, even though they're calling it depressed, that the person's not sad. They'll just say, oh, not sad, but that's really kind of the key. And then these other symptoms coming in.
So it's interesting that's a key in the distinction between depression and FTD. And you mentioned the lack of distress earlier in a number of other areas. Is that a similar experience? Is that really a characteristic aspect of what?
I think it's part of the same thing. In our data, depression is, but we find the same thing with anxiety. So that, we find lower than expected anxiety, and then even kind of specific diagnoses like, panic, specific anxiety diagnoses. And actually, one of the first paper I started off my work, it was in penetrating traumatic brain injury. And we studied one of the first papers that got me kind of interested in this and leading into FTD and everything was we found that we looked at Vietnam War veterans, and ones who had damage to the same parts of the frontal lobe that were affected in FTD, this kind of what we call ventromedial, didn't get PTSD after their injuries. And we interpreted that, and I think continue to interpret that, is if you have damage to this part of your brain, you can't mount a normal response, and that, anxiety and depression, this gets a little maybe farther afield, but I think it's relevant to this, is that they're not there just as disease states. They're there as part of our normal motivational package, and so all of us experience some anxiety and dysphoria in our lives, and you should, and it's part of motivation. So you can, and most of the time what we deal with in psychiatry is people with too much depression, too much anxiety, but I would argue you can have people with too little anxiety, too little depression, and that's often kind of showing damage to these regions. Because there's a fine line between appropriate arousal and anxiety, and they kind of go hand in hand. And these people, I would argue, don't even have appropriate arousal.
Well, and it's so interesting, and I think the value of the work and the research that's trying to look at these early symptoms is going to move into the field to be able to try to inform better awareness, better understanding, and better diagnostics. But one of the thoughts that I had as you were speaking, and that some of our attendees have also called out, is how do we go about educating providers and clinicians and those doing assessments who don't have the depth of expertise and the interest to pursue at this level, distinguishing and teasing apart some of these symptoms? So I'm sure it's something you've thought about. Are there elements, what kind of supports are there to educate professionals better? Obviously, it's something AFTD wants to do, but from within the world of the research and the work that you're doing in this area.
It's a key question. And I, being a psychiatrist, I feel also, especially in mental health, I feel that as a psychiatrist, and also just because if you look at the numbers, most of these people are being diagnosed with depression. And it's interesting because often people, I'll be in kind of discussions about this and people say, well, the problem is that we need to get primary doctors to refer to specialists. And what I respond to that often is they're actually referring. So what the typical story is that case I gave where, someone will come in, they'll be behaving differently, and the primary doctor will go, okay, well, I need a little help with this. The problem is they refer to the mental health system then, and where they don't have experience, they really don't have kind of the outlook that is appropriate to these. And then, so in a way, to the PMD, you can't say refer to it. The problem is you're not referring; they are referring. It's just going the wrong way. And so, I feel very strongly about educating in mental health worlds, and that we need to kind of increase their awareness. Now, I think some of that is like that paper I was presenting is we got to just be really do good work about what are these symptoms. But the other thing, I think we should also think a little bit outside the box of things that kind of also maybe a little easier to pick up. So, imaging is one of those, but like we have a research study going on now where we're looking at, so the amygdala, which is very involved in FTD, is very important for physiologic, blood pressure for arousal, things like that. If you look back, when I was working on these criteria, I read all the old criteria. An old criterion used to be low blood pressure for FTD. And so we're doing a study where we're saying, let's look at that. Let's look at blood pressure. Maybe that actually could help people, screen and identify these people who are not having kind of sufficient both emotional and physiologic arousal to things, and is a little easier to kind of hang your hat on, So I think it's going to, and there's some really interesting work. I think someone presented today actually is, on kind of technologies, So can you, tell from someone's phone how much they're moving around, or things like that? Can we diagnose aphasia from video, from clips? So I think some of it is kind of getting better about what are the symptoms, getting that out there, and then about working on other ways that are maybe don't demand as much expertise to kind of institute.
Well, I love that. And I love that it's looking across disciplines too.
Yeah.
So
yeah.
Certainly the mental health world is a prime target for more education. And that's where we value the work that you're doing, I think, in so many ways, but also looking across other disciplines to figure out where is the overlap and where are the opportunities to leverage and get in the door for better education, whether it's through research about a low blood pressure study. Primary care doctors more information to at least be thinking about and mulling over as a field, as a profession. And I think we see that more for sure. And that's bound to just help expand the opportunities.
Yeah. And this neurofilament chain light and things like that, I think, are going to be important, because if you did have a blood or CSF test, which could say this looks like a non-neurodegenerative versus neurodegenerative, even if it didn't tell you what neurodegenerative process it is, that could be very helpful to screen. Again, if it has to perform well, and we have to be kind of rigorous about that it works well, but it could be very helpful to kind of have a test like that.
Right, and as a tool, again, to distinguish between, do you refer to psychiatry or neurology? Right?
Yeah, and neurology, I am a psychiatrist, but neurology has generally done a better job in diagnosis, I'm willing to say. And not always. I mean, I think there are exceptions to that, but I think that, but the problem is I think people aren't going to the right people, usually.
Right. Well, I think we're at time. I really appreciate you spending time with us today, and we'll definitely be continuing to follow your research, because identifying these early symptoms and being able to distinguish them is really so important. So thank you so much.
Thanks for the opportunity. And
Thank
people, like I said, take a look at the paper. It's free, so you can get it.
We'll look it up. We'll share it. We'll find it, get it on AFTD's website.
Thank you.
Thank you all for joining us today and for tuning in. I hope that you'll stay with us for the rest of the day, and make sure to send us your feedback about what you valued about the day and the sessions that are really helpful and what you'd like to see us do in the future. So thank you all
Thanks so much.
Thanks, Dr. Huey.
Bye-bye.